Hey everyone, welcome back to the channel. This week we are going to talk about navigating extra canals in mandibular premolars. If you're new to the channel, my name's Siju Jacob. I've been in private practice for more than 25 years. I've been using a surgical microscope in my private practice for more than 20 years, and I've been training dentists how to use the surgical microscope in everyday clinical practice for more than a decade. Endodontic therapy of a mandibular premolar most often isn't that difficult to perform in clinical practice. It is one of the easiest cases because the majority of the times it is just one large canal, which most people can negotiate without much problems. The canal is usually large. However, there are the odd cases where sometimes you are faced with a clinical situation where you go in thinking that it's just one canal, but the canal bifurcates or sometimes even trifurcates. And these are the cases that most people find difficult to do. This is what we see the majority of the times in clinical practice. It's just one canal which goes all the way to the apex. And yes, in the apex, sometimes you can have some ramifications, which you often discover when you obturate these cases, especially in non-vital cases. However, most of the endodontic therapy that you need to accomplish, most of the steps are fairly easy. Most practitioners don't have a problem locating or negotiating these canals. However, when you get these sort of cases occasionally, where it's not just one canal, it seems like one canal when you start off, but as you progress, you realize that it bifurcates or sometimes even trifurcates. And the more lower down in the canal is this bifurcation or trifurcation, the more difficult it is to manage. So let's start by having a look at some of the common clinical cases that I've done in the past in my clinical practice. And I'll share with you some of the techniques or some of the tips that you can use that can help your management of these sort of cases a bit more easier. Let's start with some cases first. This is a case where the patient came with acute pain. The tooth was very badly inflamed. The clinician had prepped this tooth for a crown and then sent this patient with a temporary crown. The patient went back home, and a couple of days later, there was acute irreversible pulpitis. And the patient was referred to me for performing an endodontic therapy. And the minute I made an access, I could see a lot of inflamed tissue, a lot of bleeding. And once the bleeding was under control and we performed a pulpectomy, once you cleaned out the canals, you can see the canal bifurcates into two. So you have two separate canals in this case. And then we cleaned shape and we obturated one lingual and one buccal. And then that's how it looks. And then this is how we put a small fiberglass post and close it up, and that's the post-op. So you can see one orifice and divides into two separate canals. So this is a classic two-canaled mandibular premolar. This is another case where the general dentist did an access, found that she couldn't manage or negotiate these canals. She found that it was something odd. So she had the sense to just send it off because she realized that it's not a routine premolar endodontic therapy. And this is how I received the case in my clinic. So you can see here, there's some calcium hydroxide, which the general dentist had placed. And then when I opened the temporary restoration, you can see some calcium hydroxide. Once I removed it, I could see one canal which she had located. And then mesial to that canal, I can see the extra canal or the missed canal. So this is a case where it's not buccal and lingual. The two canals are mesial and distal to each other. So it's slightly different from the earlier case. So I found that extra canal, put some calcium hydroxide, and then a few weeks later, I recalled the patient and I obturated this case. You can see the obturation of the first canal, then the second canal. You can see a post-obturation radiograph where the two canals merge into one at the apex. And then I restored this tooth with a fiberglass post and a composite core. So that's the post-op. So you can see one orifice going somewhere along the mid-root, and at the mid-root, it bifurcates into two. So this is another variation. This is a case where a previous practitioner had performed endodontic therapy on both the mandibular premolars on one side, and then prepped the tooth for a bridge and then cemented the bridge. But the patient was never really comfortable, couldn't chew on the bridge. And then I think 4 or 5 months down the road, the patient came back with quite a lot of discomfort. And again, the general dentist removed the bridge and then referred the case to me to perform retreatment endodontics on this tooth. Now you can see here, the clinician has located one canal, but when you look at the radiograph, you can clearly see that there is a missed root and a canal, or maybe even more in this particular case. So what we did was we went back and opened up both these teeth. The first teeth you can see got a percha there. That's the fill canal, and towards this side is a missed canal. So you have two canals all cleaned and shaped, and then we obturated the tooth. You can see the missed canal here as well. And then we put a fiberglass post and composite core. The other tooth as well, you can see gutta percha here. When you remove that gutta percha up to the level of the bifurcation, you can see the fill canal, and that's the missed canal over there. We cleaned and shaped both these canals, and then You can see here those two cleaned canals, and then put a fiberglass post and core and build it up. Then you can see here that's the working length, this is the master cone, and that's the post-op duration. Radiograph here, so you can see two fiberglass posts in each of these. When you compare the pre-op and the post-op, you can see we've located both these canals and also restored it. So these are all examples of bifurcations of teeth. Now let's look at a trifurcation. Again, the referral opened up the case, found that there was something odd about this case. It was not a typical single canal mandibular premolar, so referred the case to me. This is a referral radiograph, and then this is my pre-op. You can see here the coronal part is quite wide, but somewhere in the mid-root, it suddenly, the wide part of the canal comes to a halt, and then this is a clear indication that it could either be a bifurcation or a trifurcation. So you can look at this here, you can see there are three canals, not two. In the master cone radiograph, you can clearly see there's three canals here, and that's the clinical picture. So you can see 1, 2, 3, three canals, trifurcation, and then we restored the tooth with the fiberglass post. So this is the pre-op, and that's the post-op. So another example of a single orifice dividing into three canals. So you do get these odd ones. The good thing is it's not that common. It's fairly rare, but when you do get a case, it's good to know certain characteristics of these sort of mandibular premolars and be prepared so you're aware, and you can manage these cases more predictably rather than do something iatrogenic, which is sometimes irreversible. So let's look at some of the clues or some of the clinical techniques or tips that you can use to help you manage these sort of cases better. The first of all is radiographs. Secondly, you can use CBCT. Third, there are some special obturation considerations that you need to take care of when you manage these sort of cases. You can't obturate all of them in the same way that you would obturate a single canal mandibular premolar. So let's look at some of those things, that what you need to do when you're obturating these sort of cases. And then finally, restorative considerations as well. So let's look at all these four aspects which can help you manage these sort of cases. Firstly, radiographs. So when you assess the radiographs of these sort of cases, you can see that most of them will follow a certain pattern. Now, when you look at a regular single canal mandibular premolar, you are going to find a continuous canal all the way from the orifice to the apex. But when you look at these sort of cases, which are bifurcations and trifurcations, you will note that you will have a radiolucent line which starts as a thick radiolucent line from the orifice, but somewhere in the midroot or towards the apical part, that dark radiolucent line disappears midway. And that's a clue that there is some bifurcation or trifurcation happening. So if you look at here, coronally, there's a pretty large pulp space here that shows the single part of the canal. And somewhere here, it disappears. This black part disappears. That tells you that there is a bifurcation or trifurcation here. If you look at this case, it's the same. You can see a dark line which suddenly disappears. So that's a clue, and that helps you prepare or anticipate some sort of a bifurcation or trifurcation. This again, in this retreatment case, you can see that the clinician has located one canal and obturated it, but the obturated canal doesn't have any centricity because the obturated canal is skewed towards one side. So there's a large part of this canal which is visible here. So that again doesn't follow what we call the law of centricity. That again should give you a clue that there's probably a missed canal. So these are some of the radiographic clues that you can look at. So sometimes you start these cases thinking that it's a bifurcation, but often when you take a master cone radiograph or working length radiograph, you see that the existing canals or the two canals that you found is skewed towards one side. Again, you see that they don't have any centricity. So if it is skewed to one side and then you have a large part of the tooth untreated, then again, you need to suspect that there is probably an extra canal. So in this case, there's actually three canals. So these are some of the clues that you can look at radiographically before treating these teeth endodontically. Cone beam CTs are amazing tools for virtually any branch of endodontics or any procedure in endodontics. And treating mandibular premolars with multiple canals are no exception. It is extremely useful to have this knowledge in advance, whether a canal is bifurcating or trifurcating, before you even attempt the case. That's the first part. The second part is when it is bifurcating or trifurcating, it pays to know whether this extra canal, is it present lingually or is it present buccally or is it present mesially or distally. So it gives you an idea as to where these extra canals are present, so that when you are treating these cases clinically, you know exactly where to look for the extra canals. Whereas if you don't have a cone beam CT and you're relying on only radiographs, then there are limitations. You just know that there are extra canals, but you don't really know whether these extra canals are present more lingual or buccal or mesial or distal. So that's the value that cone beam CTs give you. Let me just illustrate it with just one case of a retreatment. So you can see here, the previous practitioner has clean shaped and obturated one canal. From the radiograph, it's pretty clear that there is a missed canal, right? So the first thing we do is we take a cone beam CT, and in the cone beam CT, you can see that's the obturated canal, and the canal which isn't obturated is lingual to the obturated canal. So you know immediately that when you go back into this tooth at the level of the bifurcation, you need to look lingually and you will find the missed canal, which is what we did. So we go back in there, that's a temporary restoration. You go in there, you can see gutta percha with bioceramic sealer. And then when you open it up at the level of the bifurcation, you can see that's the fill canal. And then lingual to the fill canal is where we are looking for the missed canal, and which is what we did. You can see I've removed the gutta percha all the way to the bifurcation area here. And this missed canal is lingual to the fill canal, which is what we did. We found that missed canal lingually. You can see here, that's the missed canal. And then we clean shape and obturate that missed canal as well. So it becomes very, very predictable rather than going in there and hunting around for the canal and not knowing where it is. A cone beam CT gives you that extra information, which makes your treatment more conservative and more predictable. So very, very useful tool. This is the pre-op, and that's the post-op of this particular case. Now let's look at some obturation consideration. When you obturate these cases, the problem is most of them have a single orifice, and it is this single orifice which divides into two. So when you place a master cone, sometimes, especially if it's a tapered master cone, then that master cone will obstruct the view and accessibility of the other canal. So when you look at these cases, it's like this. You have one orifice and you put in a master cone in one canal, that cone will obstruct vision and accessibility in the other canal. So one has to take those precautions, and sometimes even take master cone radiographs with one cone in place, or sometimes two cones in place in case of a trifurcation. So one needs to alter these sort of radiographs. The second thing you need to consider is when you are using tapered master cones, they make visibility and access a bit more difficult. So for these sort of cases, it's probably not a great idea to use larger tapered cones. One needs to switch to 2% tapered cones, or sometimes maybe a 4% tapered cone in some cases. If you are using a 4% tapered cone, then you need to probably take your master cone radiograph for one canal at a time, obturate one canal, and then obturate the other canal. The other alternative is to use 2% cones, so you still have some sort of visibility and accessibility to put the master cone in the other canal. So that's one variation I would do. The second variation is many times we would put a single cone. Like if you see here, I'm using a 4% tapered cone, but I'm taking the master cone radiograph for one canal, and then go ahead and obturate that one canal. And when you do that, it's common that some amount of gutta percha and sealer will seep into the other canal as well. So we can use a small micro opener or something to just clean out that extra gutta percha or sealer which went into that canal, and then put another cone separately into that canal rather than obturating both at the same time, which is what we did. So you can see here, there's one cone here, we obturated that, then we use a small micro opener to make sure the other canal is also patent, and then we obturate the other canal as well. So you can see here, both the canals obturated up to this level, and then we build up that case. The next factor to consider is restorative considerations. Now, when you restore these sort of cases, the problem with these sort of cases is that the coronal part tends to get weakened. So if you look at this image here, you can see here, there's two canals here which are obturated at the bifurcation level. But if you see the part of the tooth from here coronally is kind of weakened, right? So rather than fill this whole part with gutta percha, leading to a hollow space, it makes sense to restore this with a fiberglass post so that this area or the coronal portion is strengthened. So you either use a fiberglass post or use one of those composites which are fiber reinforced, so that there's some strength coronally rather than just filling it, the whole thing up with gutta percha. When you do that, it's probably more prone to fracture at the neck level because there is a hollow portion in the middle. So this is the other consideration. So you will find that almost all our cases, when we treat these sort of single canals which bifurcate into 2 or 3 canals, then we restore that single, it's a straight part of the canal with a fiber post so that you get more strength. So here you can see here, we put a fiberglass post and strengthen it. In this case, you can see it's so large that we can fit 2 fiberglass posts. Sometimes it's two sizes. Now in this case, you can see I've put 2 fiberglass posts. And remember, we are not enlarging the coronal portion. The coronal portion is already weak because you need to remove a certain amount of tooth structure so that you can access these bifurcations and trifurcations. And when you do that, the coronal part tends to be weak. And to provide some support, we recommend putting either a fiberglass post or some sort of fiber reinforced material so that it doesn't snap easily, rather than filling the whole straightened portion with gutta percha, making it hollow inside. So you can see almost every case that we treat which has bifurcations or trifurcations, we restore the coronal portion with fiberglass posts. So what you see here is all fiberglass posts, 1 or sometimes even 2. And the other thing I forgot to mention is these sort of cases are a lot predictable with microscopes. There are some cases, let's say if the bifurcations are way coronal, they are not too far down the road, then sometimes people do see the bifurcations with a loop or strong lighting, and sometimes they tend to do these cases. But the problem is, when you perform these sort of cases without a microscope, what tends to happen is you tend to remove a lot more structure coronally. So if you look at this case, for example, this is a case from 23 or 24 years ago, before I had the surgical microscope. And you can see I still managed to treat this case. But the difference between now and those days is that back then I used to remove a lot more tooth structure. So you can see here, I've treated both these canals, but if you look at the amount of coronal tooth structure that I've removed, it's a lot more than what I would do now with the surgical microscope. So if you compare how a case is treated without a microscope and how it's treated with the microscope, you can see there's a lot of difference in the amount of coronal tooth structure that you need to remove to access these bifurcations and trifurcations. So that's the key difference when you use a microscope and not using a microscope. So I hope that short video kind of simplified some of the things that you need to be aware of when you get these sort of bifurcations and trifurcations in mandibular premolars. If you'd like more information like this sent across every week, every Wednesday into your inbox, then do subscribe to my weekly newsletter. You can see the link in the description below. And if you like more content like this, I usually upload 1 video every Sunday. So do check in every Sunday, click on that subscribe button so you get notified every time I upload a new video. And don't forget to share it with your friends if you found this information useful. And I'll see you next week with another video.